Good afternoon, everyone, and you're welcome to QPS TalkTime. And this is a very special edition today where we're going to have a spotlight on pediatric sepsis, so sepsis in infants and children. So just while we're waiting for people to log in, and we are expecting, I think, a large group to join us today, just to make you aware of some of the resources that the National Quality and Patient Safety Directorate have available. The Q community, if people are interested, check it out. And you can get more information on that email there. Q is a community of improvement interested clinicians and specialist professionals across Ireland and Northern Ireland and the UK. And we certainly encourage people to join that there. There's a QR code there for the March edition of Quality and Patient Safety Matters. So check that out, and we'll talk about that a little bit at the end. We're looking for some ideas for future editions. The prospectus of all the quality and patient safety education and learning programs, including programs that we run in conjunction with the RCPI, the prospectus is there telling you all the various things that are available to you, some of them online, some of them in person. So again, check that out. And finally, if you haven't already checked out the podcast series, and we do have a recent podcast on sepsis, which I'll highlight at the end, the Walk and Talk Improvement podcast, which we've done in conjunction with our colleagues in Northern Ireland, is available to listen to. So please engage with us today on X, Twitter, at QPS TalkTime. And like I said, if you don't get to see the session today, or you want to direct somebody to it, the previous videos from our sessions and today's will be available on YouTube, on our YouTube channel at National QPS. And we're also on LinkedIn. So no excuse not to engage with us on social media. So today's session, and we have an excellent panel who I'll introduce to you in a moment. It's about pediatric sepsis. This is Pediatric Sepsis Awareness Week. So we really wanted to do something to highlight this condition. And I think everybody knows sepsis is and can be a devastating condition, but there are things we can know about it and do to, I suppose, reduce the chances of it happening and to recognize it quickly and then address the problem. So we're going to have an overview of pediatric sepsis for clinicians, carers, and parents. We're going to have a parent's guide to the emergency department and when to go and what to expect if you go there. We're going to talk about how we can reduce the risk of sepsis, and we're going to look at some of the resources that are available for clinicians and carers and parents. So our panel, I'm pleased to mention or to welcome many of my colleagues here in pediatrics and children's healthcare from CHI. So Dr. Turlough Bolger, consultant in pediatric emergency medicine. Nuala Clarke is the group sepsis lead in ADON for CHI, Children's Health Ireland. Dr. Martina Healy, HSE National Clinical Lead for Critical Care and Pediatric Intensive Care Consultant, and Dr. Cilian Maoldomhnaigh, Pediatric Infectious Disease Consultant at CHI. So you're all very welcome. We have a busy panel. We've lots to get through. So I'm going to maybe hand over, first of all, to Martina and welcome you, Martina, to start maybe giving us setting the scene a little bit first and helping us to understand what is it we're going to talk about today. What is sepsis?
Thank you very much, John. So I'd like to welcome everyone on behalf of the sepsis program, and to thank John for enabling us to run this webinar. So what we thought we'd start off with, a recent HSE poll asked the question of the general public what they understood by sepsis, and what became evident was people had heard of it but didn't really know what it was. It may be that they'd heard that their granny had died of sepsis, but they didn't and weren't able to discriminate between infectious, an infection, which we often see in children, and where that progresses to sepsis. So what we're all hoping to do today is explain what sepsis is, explain what some of the red flags are and the things to look out for, and how we maybe discriminate between the children who have high temperatures and who get better very quickly and those that go on to develop sepsis. So what is sepsis? This is quite important. And basically, it's a life-threatening complication of an infection. So you must have an infection in order to develop sepsis. So we hear a lot about sepsis and septic shock. So an infection, when it involves organ or tissue damage or organ failure, may lead on to septic shock. So what we'd like to do is give carers and clinicians and parents the information so that early recognition of sepsis prevents the journey into septic shock and hence the high mortality rates. So it's the body's overwhelming response and life-threatening to an infection, and like I said, can lead to tissue damage, organ failure, and death. And it is treated most effectively if you intervene early in the infection so it doesn't progress to sepsis and to septic shock. And we do know that in Ireland, sepsis begins outside of the hospital in the community for 80% of people. So what you do in the community is very important in the recognition and early treatment of sepsis. So one of the things that makes it difficult to pick up in children are the different age groups react very differently to sepsis. So if they're under 5 years of age is a very different picture to the adolescent. So we're going to try and break that down a little bit for parents and for carers and for clinicians. So one of the big things, if they're small, particularly under 1 year, there tends to be a peak of sepsis in the children aged 1 year and in the adolescent group. So if they're under 1 year, obviously not feeding, vomiting, having very dry nappies, drowsy, maybe unusually sleepy, difficult to tell sometimes in a child. And in particular, guys, with both infants and children is, a lot of parents are very good at gauging how sick their children are. They have in high temperatures, they look awful, but within 12, 24 hours, with the intervention of paracetamol and Nurofen, they get better. So really what people worry about is, how do they know that this isn't going to become more severe and progress to sepsis? So some of the things to look out for in children and the very small babies are, like I said, if they're unable to wake up, not taking any food, dry nappies in particular, and vomiting. So in the older children, very fast breathing, obviously seizures is a complete red flag and straight to the ED. We can sometimes look for skin that's mottled, patchy, having a rash, but that does not necessarily appear in all types of infection. It's particularly pertinent to the meningococcal sepsis group, and obviously there are lots of other types where you do not see a rash. But I think things like unusually sleepy or difficult to wake up, or your child feels really cold when you touch them and hasn't had a pee for the last 12 hours. And with adolescents in particular, you may have to help them out of bed in order to go to the toilet in day 2 or 3 of the infection. So that would very much be a red flag. So what do we do when those when those children come into hospital? And I think Turlough, our ED colleague, is going to speak on this for the treatments when they arrive in ED. So the most important thing is recognition. So early recognition in the ED leads you to go down the sepsis treatment bundle. And this has been developed from a pediatric sepsis guideline, which we launched in 2020. So we call it the Take 3, Give 3. So what the staff will do immediately on arrival, if we think the patient is septic or the child is septic, would be when you're putting in an IV cannula or an IO, that you immediately take a blood sample, because if you take your blood sample before you give your antibiotics, now if you can't get a blood sample, guys, and you're seriously worried, you crack on and give your antibiotics. But if at all possible, it's very useful to be able to identify the organism, and Cilian may speak on that. And request a senior medical review. In the meantime, you're giving oxygen, you're giving your IV fluid boluses as per the guidelines, and you're starting your antimicrobials. And really important in the really small children is to request a senior medical review, because if they do need an intervention, they may need intubation, ventilation, and transfer. So our clinical guidelines were launched in 2020. They're very much in line with the International Surviving Sepsis Campaign guidelines for children, and this is to do with the management of septic shock and sepsis-associated organ dysfunction in children. We now have our own national guidelines with implementation plan, and as part of that, There is a sepsis clinical decision support tool, a sepsis awareness leaflets, and a guide to the education, which is available online. And my colleague Nuala is going to speak on that and hopefully give both parents, carers, and clinicians who don't work in the tertiary referral hospitals some idea of what's available online. So I think I'm going to pass over to my colleague Turlough, who is going to speak about the interventions in EAPS.
Thanks, Martina. That's a very clear picture of sepsis. And Turlough, you're welcome. Turlough, you work in the emergency department, so we might just take it from there. You know, why why do parents get worried that their children might have sepsis, and when should they come to the emergency department or to see a doctor?
Thanks, John. I mean, I suppose to put this all in context, first of all, you know, in the emergency department, we see lots of children with fever. You know, it's the largest proportion of patients that we would see in the emergency department is children with fever. And fever equals infection usually, but it doesn't always involve sepsis. You know, sepsis is ultimately very rare as an entity. It's very rare, but it's extremely serious. So it's really important that we would assess these children completely, take on all the concerns, and investigate as appropriate. The first thing I would always say, you know, is it's really important to listen to the parents. You know, when a parent is concerned about their child, it's really important. It's an old adage in pediatrics that when mum is concerned, we should be too. You know, and I think that certainly is a good sign for doctors, you know, who are well trained, that they take those concerns on board. The mum knows their child, their baby best. You know, they spent a lot of time with that child or infant or older adolescent. They know what deviation from the norm in terms of behavior is. So it's really important we listen to that. And that should result in the emergency department in a good assessment, a proper assessment of the concerns and addressing all those concerns that mum has or the parent has. And it needs to be a full clinical assessment that's accurate, you know, not just the situation where I'm sure a lot of parents and families have had the experience where they go to the doctor and they're just told, oh, it's just viral, you know, and they're kind of back of the hand, they're disregarded and sent away. So it's fine to say that, because a lot of children who present with fever are viral, but the only way you can say that at the end is by doing a good history and examination and determining that that is actually what is going on. So as long as that final diagnosis is preceded by a good history and clinical examination, then I think you can identify sepsis, identify more serious infections. So it's really important that assessment takes place. And I would say, you know, in terms of investigations in the emergency department, they often aren't required when a good history and examination is done. You know, that once you do a good history and you're looking for red flags, you're looking for concerning features in the history, the bloods don't add a huge amount. You know, when you have concerns in the history, the bloods absolutely determine further treatment, further disposal, maybe to an inpatient bed or up to ICU. But as a blanket thing, if I was to do bloods on every patient coming through the department with fever, I wouldn't be able to interpret them, because I haven't first identified who is well and unwell. So when I talk about looking for red flags in the history, okay, there's a few things that you should really be focusing on in your first interactions with the family and the child. A child who comes into the department with a fever who's unvaccinated, that is very significant. You know, in terms of protection against infections and common infections, and I've lived through a period as a pediatrician where we had no meningococcal vaccine, and there was 2 or 3 cases a week coming in of meningococcal sepsis, and that's much rarer now with vaccination. So unvaccinated status is a very important feature on history. Also, you know, if it's a small baby, a neonate, in the first 4 weeks of life, they're much more at risk. Their immune system is very poor, and they're much more likely to get infections. Other elements in the history, like say burns, wounds, you know, penetrating wounds, things like that, chronic conditions, there, you know, maybe other reasons for them having low immune systems. All these things are really important. And recurrent UTIs as well is another one that I would say is just an important feature, because that can often lead to sepsis, like a UTI becoming more unwell.
Recurrent urinary tract infections, yeah.
Yes, urinary tract infections. So, kidney infections and things like that, definitely very important to get that detail in the history. And the next thing that I'm doing a lot of the time, in my first few minutes in assessing this child, is I'm trying to decide, is this child well or unwell? Okay, and that is a fairly nebulous kind of concept for non-medics, to try and say, well, is my, every child who comes with a fever is unwell, but that's often not the case from our point of view as people who are trained to kind of assess whether that child has a very serious invasive illness. So those kind of features of wellness are really determined by looking at their feeding patterns. Or they're feeding way down, maybe less than 50% of normal intake. What's their urine output like? Are they having plenty of wet nappies? Have they really started having dry nappies or not passing urine? Their bowel motions, are they passing any bowel motions? Generally, what do they look like? What's their color like? Are they pale compared to normal? Are they lethargic compared to normal? Are they quite irritable compared to normal? Those are the things that would really make me decide, is this child well or unwell? And regardless of anything else, if I saw a child who was unwell, they get lots of investigations and lots of referrals up to intensive care units and to inpatient beds and so on. When we get into the specifics of the history around a child with fever, okay, there are some kind of myths around fever. Fever equals infection. When do the features of fever make you more concerned and concerned about sepsis? Well, firstly, I'd say that, rarely, but it can happen. You might have a child who's septic who doesn't have any major fever. So that's one element. The child presents who's unwell with no fever, cover them for sepsis. What I if the fever goes away and they're running around the waiting room and they're, playing chasing with the other kids in the waiting room, they're very unlikely to have sepsis. They will obviously be upset and irritable when the fever is there, but when the fever settles, if they run around and they're back to themselves, that's a great sign, and you can be very reassured around that for the few days while the fever is ongoing. Whether they respond to paracetamol or Nurofen makes no difference whatsoever. Okay, that is those are very good drugs for bringing the fever down, whether you're septic or not. So it really doesn't have any effect. And septic kids can have fevers for very short times, or they can have fevers for 2, 3, 4 days. So the duration of fever isn't that important. But I mean, a long duration of fever, like longer than 5 days, is very unusual for a simple viral infection. So I do think of other conditions when the fever's gone on for 5 or 6 days. They might have some other infection, like maybe an infection in the bone, or they could have some other diagnosis, like a pneumonia or some other thing that's going on in terms of causing this fever. And remember as well that sometimes viruses can be the opening for a sepsis event to happen. So a child can present with a flu-like illness, can be unwell with a bit of a fever for a few days, be kind of getting better, but then the bacteria comes in afterwards. So that's another reason to be concerned when the fever doesn't settle after 5 days. So that's kind of my little bit of a red flag there. And I always look for other symptoms with fever. So because you can have kidney infections, pneumonias, bone infections, and these things can lead to septic events where the infection becomes more widespread and the child becomes more unwell. So you're looking for symptoms related to the chest, cough, breathlessness, or pain walking. Bone pain is a really big one, especially in older kids who can tell you if they've got a fever and they've got pain in their limbs, it's a real red flag for invasive infection, a very high rate of sepsis within those kids who present with pain in the bones. And it can be difficult because kids with flu-like illness, they'll have muscle aches and pains as well. So, but if you think your child's got pain in the limbs with a fever, definitely would be a red flag for me to be assessed by a competent doctor. And as I say, once you've identified sick kids and kids with sepsis, it is about the interventions, urgent interventions, the get 3, give 3 that Martina was talking about, getting your bloods and your blood cultures and checking the urine output, and giving oxygen, fluids and antibiotics to make sure that you're kind of really addressing that sepsis early and intervening aggressively to make sure that they don't get sicker while they're in your department.
Thanks, Turlough. And I suppose it's the emphasis on, like you said, the clinical assessment. And a lot of these are elements that parents can and carers can check at home. A lot of these some of those red flags, the same things
Yes.
we look for in hospital, people
Yeah.
are looking for at home. And like you said, I think that response, to removing the fever, and not, whether a child is much better when the fever is gone. I think that makes it a lot
Yes.
easier to assess them.
Yeah.
What about this whole idea that when people come to see the doctor's happy, there's no evidence of sepsis at that time, but a parent goes home and the child doesn't improve or the situation changes, and I think that can be difficult for people to know when to come back again.
Yeah, I mean, I think it has to be an open door policy from any clinician who's seeing a patient whose parents are concerned. I mean, we talk about safety netting of patients, to make sure that they've got good advice and information as to when to come back and when to reattend with their concerns. And it does come back to those, is your child unwell questions. What's the feeding like? It should pick up. It's very unusual for a child to have a simple viral illness causing a fever who's still off their food 5 days later, who's, not passing urine properly, who's, a bit lethargic on the bed. I would agree as well, in terms of the difference between the young kids, the babies and the older kids. The babies sometimes can be easier, to notice in one sense, because we're changing their nappies all the time. We're feeding them, you know what's going on. But the teenagers, present with much more kind of flu-like fatigue, very lethargic and difficult to mobilize around the place, bone pain, very different presentations than a small baby who presents with sepsis.
Yeah. So again, just being aware of different age groups. So back to this point about the risks, that there's underlying groups or risks. And when we talk to Cilian, we'll talk about what we can do maybe about addressing some of those risks.
Yeah.
Thanks. Look, if a child comes to the emergency department and they're diagnosed as having sepsis, occasionally they will need their care escalated to the intensive care unit. And I might just come back to ask Martina about that. What happens to children, Martina, if they're diagnosed with sepsis in the emergency department and we feel that they need a higher level of care that can be given in the emergency department or on the wards for pediatrics? Some of these children will need to go to the intensive care unit. Could you describe what happens in that scenario, please?
Yeah. So what Turlough is describing is the number of children who present with infections. So we wouldn't see those. So Turlough and his team would be very much good at screening them and obviously recognizing the ones that might need to proceed to ICU. So just to reassure people, sepsis and septic shock is pretty rare in children. There are less than 1,000 cases every year in Ireland. I think it's important to point that out. And even rarer is to go from sepsis into septic shock. So what we're really doing is relying on the ED team and the medical teams to pick up the infections that are proceeding to sepsis without going into septic shock. And that's where the early intervention with the oxygen, the fluids, and the antibiotics. So if you do need to go to peds ICU, it usually means that they have an organ failure as well as the obvious signs that we've talked about, the sleepiness, the drowsiness, the failure to pass urine. So what they need is, and what we do, is organ support. And that can be in a number of ways. Sometimes, say, if, for example, it's a pneumonia that has progressed to sepsis, then we would intervene with either a non-invasive ventilation, which is a mask over your face to aid it. But usually, if it's a pneumonia causing a degree of organ failure, you would be talking about putting a tube down, and these children would require ventilation for 2 to 3 days, which is a fairly big undertaking, but is a very successful and safe treatment for children. The ones most in risk of requiring that are the smaller babies, and we probably see this to some extent with our little group of babies that have RSV. They often have a secondary pneumonia and require intubation and ventilation. So they may need other organs supported as well, the main ones being you take over their breathing, you feed them through their own feeding tubes, and sometimes the kidneys fail, and that's really heading towards severe sepsis, septic shock. We may have to take over the kidney function for a period of days before the child's own kidneys start recovering. And I'd like to point out this is rare, but I suppose what our talk is all about really is preventing the children from getting to that stage. That there are a group of well children who present with infection, sepsis, who get sick, and they are the group that we want to be able to intervene early on and prevent getting to the stage where they require any of those treatments, which are quite invasive, obviously. And there is a mortality with sepsis and septic shock, much smaller in children than it is in adults, but there is 4% of our population that come in that, can die from sepsis and septic shock.
Yeah. But important, like you said, to emphasize that most children who go to ICU will recover and make a good recovery.
96% will recover. And also some of the children that don't survive sepsis often don't get to us at all, John. So they're the ones we're really targeting today. These are the ones that we'd like parents to have information about, so they can see if their older child or adolescent isn't getting better and they're not happy. Don't be afraid to ask the question, guys. This is what this is all about. Could this be sepsis? Let someone else prove it isn't, but don't be afraid to advocate for your child or your patient and ask, could this be sepsis?
Thanks, Martina. I'm going to just ask Cilian maybe to come in here. Cilian, we've talked about, obviously, if we pick up sepsis early and get people to ICU, and the outcomes from ICU are generally very good. However, we know from listening to Turlough earlier that there are risks and that there are things that we can do to prevent sepsis. And I was wondering if you could maybe talk us through some of those.
Sure. And yeah, I'd be a bit repetitive and repeat some of what Turlough and Martina have already said about the idea that sepsis is organ dysfunction secondary to infection. That every child will get an infection, every child will have a fever, and fever is not a marker of sepsis, but it's those children then who go on to become unwell because of their infection. And we know that basically any infection can cause sepsis, and normally it's a bacterial infection, but as Turlough mentioned, it could be a pneumonia that's doing it, it could be a skin or soft tissue infection, it could just be in your bloodstream. But it's an important thing that parents kind of know, that there isn't one blood test that gives us the answer to sepsis. We don't have a test that tells us if somebody's sepsis. It's about the history and the exam, as Turlough mentioned, what their observations are like in the emergency department or with their GP, and how those change over a period of time. What we can do with blood tests, perhaps, or with other tests that Martina was talking about, was trying to diagnose where that infection is coming from, and that might help us, guide our treatments. And then keeping that in mind, that we have lots of different infections with lots of different bacteria that can potentially cause sepsis. We do have lots of vaccines that can prevent invasive bacterial infection. And I think it's a really important part. Turlough mentioned that already, that we know the child who is not vaccinated have higher risks of serious bacterial infection. So that vaccinating with the routine kind of IRIS schedule that we have covers lots of invasive bacterial infections. And another thing that we spoke about was the idea of kind of secondary deterioration from viral infection. We know that a proportion of children with bacterial infection and significant serious bacterial infection that can lead to sepsis have a preceding or intercurrent viral infection. So one of the ways, again, that we can reduce that risk is by vaccination. And a vaccine that is, again, part of the schedule. We do have viruses as part of our routine schedule, but our annual flu vaccination is a very good way of improving our outcomes with flu, hopefully reducing how unwell we are with flu, and then the risk of secondary bacterial infection. And that's a very easy vaccine to give. It's a nasal, up the nose shot for children, so it's a very straightforward, very easy thing to do, and we know that we have poor uptake on. And that's certainly something we can do. Again, it isn't going to affect the vast majority of children who get sepsis, but we can potentially reduce by a small number each year the children who end up with.
And that is freely available to children, isn't it?
Absolutely, yeah, freely available, very easy to give. I get my child her flu vaccine every year. Everybody in our house gets our flu vaccine every year. Yeah. So I think that's just an important thing to recognize, the importance of vaccination, because sepsis isn't is a final pathway, final common pathway of lots of different infections. And while we can't potentially reduce the risk of all of them, we can certainly help reduce the risk in a lot of them. I think just to kind of mention again the red flags that Turlough was talking about in that secondary deterioration. If you have a child with a viral infection, and you know, they can get a bacterial infection on top of that. So if you are being assessed by somebody who diagnosed you with a viral infection, they may be correct, and that situation might be different 24 or 48 hours later. And particularly in situations where maybe a fever has gone away and as part of the same illness comes back again, that's unusual for viruses to do that. I think it's an important thing to recognize. And then chickenpox is another thing that we kind of say that the chickenpox fever shouldn't last for very long, and nor should they come back. You know, so we come with secondary fever in chickenpox or prolonged fever in chickenpox as being kind of other risks for infection that again may lead on to sepsis.
So it's knowing these risks and kind of where they show up, both for parents, I think, and clinicians, isn't it? And what about, I mean, if viruses are often kind of precede, you know, possible bacterial illness and then sepsis, what about treating viruses with antibiotics early in the course? I mean, is that something that we can use to reduce sepsis?
Sadly, no. It's something that people kind of go to antibiotics as an idea to treat infection, but you know, antibiotics don't do anything for viral infections. I think it's really important that we kind of emphasize that. You know, viruses, we actually don't have good treatments for the vast majority of viruses, and then it becomes, and some people get very sick just with viral infections, and then it's about, you know, supportive care and getting people through the virus, but rarely without actually directly treating the virus itself. And we know that if we, you know, have a blanket approach to treating, you know, all infections, you know, particularly viral infections, for antibiotics that don't do anything for them, what we end up doing then is driving resistance. So those antibiotics are much less likely to work when you are actually have a bacterial infection and you need those antibiotics.
Yeah, super. Thank you. I'm going to go to Nuala next, and Nuala, we talked earlier about the importance of listening to parents. And I think one of the things we like to emphasize is that parents also listen to themselves and trust and have confidence in their own voice. They know their children better than anybody else. But what are your thoughts on that, and how can we help parents?
Yeah, no, thanks. I think that's a very important flag for sepsis for us, certainly, and certainly when we're doing our education, both for clinicians and for families. It is about listening to that inner voice, about that gut instinct that your child isn't well. And then I suppose in order for children to get the best opportunity, they need to present for medical review, and they need to be comfortable to do that. And so I think part of what we're trying to do today is to ensure that we are being very clear about the signs and symptoms. It's very hard to pinpoint what worst looks like to a parent. You're saying, now if she gets worse, come back in. But that, so the immediately parent is going to say, well, what is worse? And a lot of the time that is, they instinctually know what that is. So, and it is exactly as the panelists have outlined earlier. It's about not improving. It's about not getting better despite being on antibiotics. It's about, you know, going to, you know, whether you've been to a GP or not, that child is still not getting better. Certainly parents that we've spoken to whose children develop sepsis, they 99% of the time said there was something different about her being sick this time. They were able to pinpoint this difference in how they normally are. And I think as clinicians, and certainly people who work with children, it's important that we ask that question of parents. Why are you so worried today? What has made you more worried? And particularly for children that have communication issues or intellectual disability, it's very, very soft, subtle stuff that the parents are really perceptive to, that we wouldn't necessarily pick on. It could be something as simple as not making eye contact. And certainly some of our children would maybe manifested in behavior. So you might see more irritability, hyperactivity, and we may not pick up on those cues, but parents will always do so. So I think, you know, for parents, what we're saying is we are listening to you, and you need to make sure that we are listening to you. So if you want, you know, if you're concerned, go to your GP, or if you come into your emergency department, make sure that you are, you know, feel that you're in a comfortable space. We have experts on managing sepsis in our hospitals and in our healthcare services, but we're not expert on your child. And that's what our message to parents. You are the expert on your child. So don't be afraid to come forward and say, could this be sepsis? And if our parents do ask us that, then again, we have you know, an obligation as clinicians to stop. If a parent asks me, could this be sepsis, then that is a cue for caution. That is a big red flag for me to say, this mum is obviously concerned. I'm now going to do a full clinical examination on this child, and together we'll work in tandem with the parents to see, can we identify what worse looks like. And when we're teaching nurses and we're talking about identifying sepsis, it's always about trying to figure out, is the child getting better? Are they getting worse, or are they remaining the same? And sometimes remaining the same is not a good thing. We have them on a treatment plan and they're not improving. And that we've got to ask ourselves why. So I think what I would implore parents to do is to say to them, regardless of, somebody have said to you, this is a viral illness. If you instinctively feel your child is unwell, then you come back into us and we will see you, or go to a GP and make sure that you are seen again and express your concerns and your heightened concern as a result of, I suppose, nursing this child for a couple of days. Sometimes I'd say to parents, sometimes it's useful to keep a little diary, even, because if you've had a couple of sleep deprived nights with a young child, you can't remember what day did they have a nappy, how much did they drink. It's very hard to remember all of that stuff, and it's really useful when you're trying to come in and give a history that you've got some sort of clear information that you can give to us to help us, get to the root cause of that illness.
That's super, and I think it's a theme that's coming through, and I think the idea of could this be sepsis, and I think sepsis is one of those conditions that keeps us all humble. I think it can be difficult to diagnose, and I think no healthcare professional would ever take offense, and indeed many would encourage, like Martina and yourself have done, the parents to ask, please, could this be sepsis? And I think people. Professionals should be asking that question themselves all the time, but I think if parents want to ask it too, I think it'll be welcome. I think that people do that. Nuala, do you have some resources, or could you point us to resources that are out there for people to use and to look at?
So we've got a myriad of resources on our HSE Sepsis website, and we have them identified into clinical staff and into the public. So for our clinical staff, in particular for our paediatric resources, we have our clinical guideline, and that's really useful. You can download that as a web link, and it's very handy to have on your desktop, because sometimes you just need to kind of refer back to it, and it gives us very clear indication as how to manage children with septic shock and sepsis associated organ dysfunction. We have our sepsis tool, which is utilized in all hospitals that see children, and this is a kind of a screening, treatment and referral pathway. So you're only seeing the front side of it there. And there's very clear signs of what to do if there's a red flag, which is serious concerns, and how to escalate care. And we know that, you have to pick up the form in the first instance to look at these flags. So if you look there in the bottom of the screen on the far right, we produced a little prompt card for staff to carry on them, because we were cognizant of the fact that you might not have the sepsis form to hand when you go in to look at a child. So we have little prompt cards to remind us what our flags are also. The sepsis pathway has been incorporated into our early warning scores and all our PU charts, so you can see that again in the red and orange there at the bottom of that. So there are constant reminders to our clinical staff to rule sepsis out on any child that's unwell. And then there is an obligation, and a mandatory obligation, for all clinicians to complete a sepsis education. And so we have an e-learning program in particular to children. We have one in adults as well, for the management of sepsis in children. And that's a 45-minute program. It's mandated for all hospitals who see children to complete. So they're the kind of resources for clinical staff, and we've lots of other resources, that they can avail of as well. So from our public, a lot of these resources we have around our hospitals, but we've got specific paediatric leaflets. We've got a second leaflet there underneath is an all-encompassing sepsis leaflet that was sent out to GPs and pharmacies last year, to all GPs and pharmacies, and it's identifying sepsis in adults, infants and children. We have banners identifying, we're sitting behind one, myself and Martina today, or be in front of us. In fact, we're behind, you wouldn't see us. But we have banners that identify the signs and symptoms of sepsis, and we have videos running in our waiting rooms. And really, all we're trying to do is reinforce the same information for parents to say it's okay, to think about these signs and symptoms. So if you're in a waiting room to be seen in ED, by the time you maybe get into to see Turlough, you can say, well, actually, I was looking at that poster and my child has this, this and this. And it's useful. It's a useful prompt. Yeah. And then we have posters and little cards that we can give out to parents. And we do a lot of awareness within our acute hospital group, and I will speak at any bun fight at all. If you want me to come and talk, you ask and I'll come. So I've done a good bit of public awareness. I'll do clinical awareness, and I think it's just about continuously driving home the same message.
Thanks, Nuala, that's fantastic. And I think it really is the partnership, isn't it, with parents?
Yeah, there is an actual website for parents, which is hse.ie/sepsis, and there is a little video that we've done for parents, and the leaflet is on that. You can, as Nuala says herself, you can screenshot the leaflet and stick it on your fridge. The hse.ie/sepsis one is for the public.
Fantastic, thank you. And again, I think that's that emphasis on the clinical diagnosis, you know, rather than maybe special tests, that we must work in partnership with parents. Parents, like you said, know their children better than anybody else and see stuff that the rest of us, you know, may not see as easily. So that's great. I'm going to go over to Juanita and see if we have any questions from our audience, and we can put them and maybe have some discussion with the panel.
That's perfect. And thanks very much. I've two small kids at home, and I'm listening myself here and sort of saying, would I be going to the doctor? When would I be going to the doctor? And I suppose there's a question here just to say, as a parent, how best can you advocate for a child being seen in a crowded ED that might be short of staff? And I know, Turlough, you'd put in a response, but maybe would you like to speak to that?
After a child has been triaged, we would tend to say they need to be seen in 10 minutes or an hour, or 2 hours, depending on the severity of the presentation at the time. And unfortunately, with the volume of patients coming through, we often miss those targets, to be fair. So if parents are concerned about their child waiting in the waiting room and they feel as though they're getting sicker, absolutely, they should be able to come to the nurse's station and say, look, could I be re-triaged? Could I be rechecked to see how things are going? I'm concerned about this and that, a rash evolving, or child seems a bit quieter than previously. All of those would be certainly reasonable to come up and get the child essentially re-triaged. And then if the vital signs are deteriorating, then you might arrange for that child to be seen quicker with one of the doctors. It just gives that reassurance in managing the waiting room, because I think we have to do that as well. We have to manage the patients who we're seeing in the department. We also have to manage the patients who we haven't seen. And that goes to, say, in terms of John saying, let's focus on the proper clinical assessment. If we rely on blood tests and other unnecessary investigations which take time and resources, then you will be missing the sicker child in the department who's sitting waiting to be seen, because you're waiting on a whole lot of blood tests on children who shouldn't have got them in the first place. So it really is about, being judicious in your use of assessments, but also being accurate and complete in your assessments of patients when you do see them in the department.
Okay. And I know definitely as a parent, like I've had to use our local ED department, pediatric department, for the kids at different stages, and you don't ever really want to end up in the hospital if you can avoid it. But are there times, when a child is unwell, that you should be going straight to the emergency department, and that you should bypass the GP? Usually the advice you get is you go to the GP first and you have the conversation with the GP, but are there ever times or flags that you'd be saying, yeah, in that instance, go straight to the emergency department?
Again, I suppose I'd be deferring to the parent who is looking after a child who's very unwell. If they look at a child and they think, this child is extremely irritable, or extremely lethargic, is not passing urine, those are kind of signs that certainly I'd be saying that child needs to be seen. We said, it needs to be passing around every 12 hours. If that child has dry nappies, there's not much a GP is going to be able to do about that, in terms of hydration or rehydrating that child, kind of creating that extra fluid to make that child turn the corner, whether that be a virus or whether that be a bacterial infection, So, yeah, I'd say those are the kind of signs. Certainly the urine output is a very, very important sign. That's kind of objective. You can certainly, I wouldn't want parents to be standing over their child counting heart rates and all this kind of stuff, but definitely you can look and see how your child is doing in terms of intake and output. It's a very common thing that parents do every day, probably do better than most of certainly better than me when I was a trainee in pediatrics. And so, I think you know your child best, and if that's going off input and output, then definitely get assessed either by the GP or by the hospital.
Okay. And the other thing, and you have touched on it a little bit, but just it's fair to say that a child doesn't need to have all of the symptoms at the same time to raise a concern. Is that reasonable?
Yeah, I would think so. Yeah.
Okay.
I'll pass over to some of the other team members, but I think I would agree. I think any red flags that are there would need to be addressed urgently.
Okay. That's helpful. What I'll do is I'll pass back over to yourself, John. I'm conscious it might be helpful to get some comments from the panel in terms of their final thoughts. And what we'll do then is we can share some of the resources then into the chat. Brilliant.
Yeah, thanks, Juanita. Just again a question there on communicating the risk to people who do not believe in vaccination. I think it's important, that we recognize that is a very big group of people, and I think there's lots of reasons. But Cilian, your thoughts briefly just on how we get people to engage better with vaccination and the benefits it can bring, particularly in reducing your risk of sepsis.
I think it's a really important conversation that we all have with people who are vaccine reluctant, and it's important to kind of find out where their information is coming from and to try to address the particular concerns that they have, because a lot of what they are worried about are things that are very easy to come back with very good evidence to say that they're not things to worry about, that they are things that are propagated on the internet perhaps that are just not true, and that there is often an agenda behind people who are doing those things, which is generally monetary a lot of the time. So and then there are a lot of people then who have genuine concerns, and I think it's important to acknowledge those concerns and try to be able to talk through them with good evidence behind the vaccines that we have, which we really do. Vaccines that we give are very safe. They are effective vaccines at reducing significant infection, whether that's bacterial or viral infection. So I think when you're in this scenario that's been presented to us here, that's somebody now who's presented to the hospital with a sick child who has fever and blanching rash, and really you're kind of potentially past the point of communicating the risk of sepsis, and you're now assessing them for sepsis. That's really what you're trying to do now, is that you want to see, their risk of sepsis has increased certainly because of their lack of vaccination, but now you're into a situation where you're trying to assess them. And a child with a fever and a non-blanching rash is always a concern for us for a particular type of sepsis caused by meningococcal disease. And just to go back to one of the points that Juanita asked there a minute ago, is there a particular group, Turlough? I think that, fever in a very small baby, I think, I don't know what cutoff you would like to use, John or Turlough, but certainly probably under the age of 6 weeks, a temperature over 38 degrees is almost an automatic admission to hospital.
Yeah.
So I think that is a scenario where I think it is reasonable to go straight to your emergency department. There's a lot of debate in the worldwide literature about what that cutoff should be, but certainly any baby under the age of 4 weeks with a true fever, so over 38 degrees and above, and probably realistically anywhere from 4 to 8 weeks should go into an ED, because the assessments that are required, which is kind of a full septic workup, because babies are bad at telling us that they have serious infection, can really only be done in a hospital setting. So I think that's probably one scenario I wanted to ask you to answer your question of where you would bypass the ED. I hope that's fair to say to her like that.
That is, yeah.
That's a reasonable thing to do.
Yeah.
Fantastic. Folks, we're coming towards the end. I suppose it is Pediatric Sepsis Awareness Week, and I might just go around the panel, and I think we'll probably be reiterating important messages that we've been giving. But I'm going to start with Martina and Nuala there, maybe first, just for your final takeaway messages for the group online today.
Well, I suppose we'll be singing the sepsis mantra, which is, if you're concerned, if you have any concerns about your child, come in and see us, and don't be afraid to ask, would it be sepsis? That is our key message. Martina?
I think just not to alarm people, sepsis is rare in children, guys. It isn't your normal high temperature. It is rare. Parents are very good at managing high temperatures and children with viruses. But when you're concerned that it hasn't gotten better, or you think your baby's become more sleepy, floppy, like we said, no wet nappies, or your adolescent is not getting better, there is nothing wrong with going to either your GP as an emergency or your ED and asking the question, I'm not happy, could this be that?
And just maybe, Martina, and sorry to come in there, John, there's just one quick question after coming in. How long does it take to recover from sepsis? And how long does it take for sepsis to turn fatal?
Yeah. So how long does it take to recover from sepsis? So in the group that developed infection to sepsis to septic shock, there is a kind of a different group. So straightforward sepsis that's been treated, usually would spend between 2 and 3 days in intensive care. If you progress to septic shock, this is where it takes much longer, where if you're using things like your organ support, like your ventilator and your renal dialysis and so on, and that can take up to 10 to 15 days. There's also a huge recovery time when they get out of ICU. Cilian might want to say something about that. Takes a long time, even longer for adults. So number one, is prevention. Number two is pick it up early, and number three, don't let it develop to that stage.
It's really helpful. Thank you.
Thanks, Martina. Cilian, if you want to add anything to that, and we might ask you for your takeaway message as well, please.
I think takeaway messages are the same, in the sense it's recognition of sepsis is, and that's a message not just for parents. I think it's not just an onus on them, but an onus on all of us to try to think about sepsis. To try to recognize sepsis is not always easy to do. As Martina says, thankfully it's a rare event, and every child will get infections, every child will get fevers, and then just to emphasize again, if you look at prevention and what we can do to prevent significant infection, it's vaccination. Yeah. And I really, it's something that we really have to emphasize as a healthcare community, the importance of vaccination. There's a lot more mistrust at times, and a lot of that mistrust is something that we can hopefully encourage people around to get kids as protected as possible.
Thank you. And Turlough, I'm going to give you the last word on message for our Pediatric Sepsis Awareness Week.
I would say my message is to the medical staff to take good histories and do good examinations, and to be very clear, about that I've assessed this child for sepsis on every occasion. And if you do that, then the chance of missing it is much less likely. So having it in the forefront of your mind and taking good histories, not just a history, a good history, with all the risk factors and all the features that we're looking for, and we'll miss less of those cases, and we'll spot the evolving cases.
Yeah. And use the form, guys. Like, there is a really useful form, which everybody hates filling them in, but I always think it's more of a reassurance. Turlough, would you agree? You can run your eye down the form, and Nuala will say fill it in. I would say run your eye down the form. And if you're happy that the red flags haven't been raised, you're not worried about sending someone home, and you haven't missed something.
I think we'll leave it there, folks. Thank you so much. I think there's a lot of takeaways. There's some really good feedback there from people. I think I absolutely endorse everything that's been said, and I think stay humble with this one. And I think nobody I think will mind being asked, could this be sepsis, from our colleagues, from parents, and I think we can do this together. I think it's very important that we all work together towards reducing sepsis. So thanks everybody on the panel. Like I said, you can follow us on social media. There is a sepsis podcast on the Walk and Talk Improvement podcast. So again, if people are interested in learning more there, so again, talking about reducing and managing sepsis, what you need to know as healthcare professionals. So you can check that out wherever you get your podcasts from, and there are several other good podcasts there to listen to as well. And so finally, if you wouldn't mind, again, just use the QR code to join our mailing list. And I think that's it from us today. I'd like to thank our panel again, everybody, and we will see you on the 14th of May.